Good afternoon, everyone. Thanks to the organizers for having me here today. I will be talking about RePORT India and HATHI implementation research on alcohol use among TB patients with or without HIV. So, unhealthy alcohol use is on the rise in India, and according to a survey on substance use conducted by Ministry of Social Justice and Empowerment in 2019, report an estimated 50.7 million people suffer from harmful or dependent use of alcohol and require some kind of intervention. And this is important because alcohol use significantly increases the risk of developing TB. A recent TB prevalence study showed that people who consume alcohol have a 4 times higher prevalence of pulmonary TB compared to those who do not drink. Additionally, people living with HIV are 18 times more likely to develop TB. With India having the highest global burden of TB and the third highest burden of HIV, alcohol use adds another layer of risk and can worsen the health outcomes of people with TB and HIV. Additionally, I would like to highlight our own work under RePORT India Consortium Phase 1, where the C-Triumph study was conducted in BJ Medical College Pune and National Institute of Research in Tuberculosis Chennai, and it collected relevant clinical, socio-demographic and psychosocial data at multiple time points over 24 months of follow-up from adult and pediatric TB patients and their household contacts. And the aim of the study was to measure the host and microbial factors associated with TB treatment outcomes and progression from infection to active TB disease. So, C-Triumph data on alcohol use among adult TB patients are published in International Journal of Tuberculosis and Lung Disease, and it demonstrated a high prevalence of unhealthy alcohol use affecting approximately 40% of TB patients. It also reports unhealthy alcohol use as a major contributor to TB default failure and mortality among TB patients. And these findings highlight the urgent need for an evidence-informed intervention that can effectively reduce alcohol use among TB patients, improve clinical outcomes, and can be integrated in TB care. And if we look at the National TB Elimination Program in India, we find that although program has made great progress over the years, one important gap still remains. Alcohol use is not being systematically addressed. A study by NERT and a survey by Government of India have shown that alcohol screening and intervention aren't yet part of the routine TB care. There is no clear policy or guidelines for managing alcohol use among TB patients. Healthcare providers often don't have training to support patients with the alcohol use, and we don't have scalable models to deliver alcohol intervention across different TB care settings, and same is the case for HIV program. So, evidence-based alcohol treatments are available. However, numerous individual and structural barriers limit access to these treatments. And with regular contact that people with TB and HIV have with the providers during the active TB and HIV diagnosis and treatment, integration of alcohol treatment into existing TB and HIV care may increase the treatment access, overcome patient and system level barriers, and improve treatment outcomes. Our team of investigators conducted a randomized controlled trial among people with HIV in Vietnam, where they evaluated the two scalable clinic-based intervention within ART program, and this study reported that the brief intervention arm showed a significant increase in abstinence from alcohol as well as improved viral suppression at month 12. Another randomized controlled trial in India by our HATHI co-investigator Dr. Nadkarni and colleagues in primary health care settings in Goa reported significant reduction in alcohol use in the intervention arm as compared to standard of care arm. And in the TB context, a study by Dr. Beena Thomas and colleagues reported that a 4-session alcohol intervention in Chennai improved the TB treatment outcomes. So, having these evidence-based effective intervention modules available, we designed a hybrid trial for alcohol reduction intervention among people with TB and HIV. We received funding from National Institute of Alcohol Abuse and Alcoholism, NIH, and the overall aim of the study is to assess the effectiveness of HATHI intervention as compared to standard of care in reducing alcohol use and the clinical outcomes. And the HATHI study is conducted in 3 phases. During the first year of the study, pre-implementation phase was conducted where we adapted alcohol reduction intervention. In implementation phase, a randomized control trial was conducted with 2 aims. First is to assess the effectiveness of HATHI intervention in lowering alcohol use, and second aim is to assess the effectiveness of alcohol intervention in improving TB and HIV outcomes. Third phase of the study was implementation evaluation, where we used mixed method approach to assess the implementation barriers, facilitators and costs. So as part of pre-implementation phase, we used qualitative method to adapt the intervention to the local context, where we conducted 3 focus group discussions with TB and HIV healthcare providers and 20 in-depth interviews with people with TB and HIV and unhealthy alcohol use, their family members and TB and HIV experts. And we obtained their feedback on the information presented in the intervention manuals, which includes like effect of alcohol use on human body and TB and HIV treatment outcomes, mood and triggers for drinking and how to handle them, and motivating statements to cut down or quit alcohol, and the behavioral skills required to achieve the alcohol reduction goal. So our intervention adaptation process involved with brainstorming discussions, going through each intervention session with the study team, followed by modifying our HATHI intervention manuals and patient workbook based on the themes emerged from the qualitative study. And after we revised the intervention manual, we then piloted the adapted version with 10 stakeholders: 5 people with TB and unhealthy alcohol use, 5 TB and HIV healthcare experts, examining each session in depth and assess them on dimensions including content comprehension, intention to change, feasibility of applying the content in clinical settings, client satisfaction, relevance and skill acquisition. Thus manual production was finalized for the trial, and this use of co-design method involving all stakeholders in shaping the intervention ensured that the intervention is both contextually relevant and patient-centered. So final HATHI intervention based on cognitive behavioral therapy and motivational enhancement therapy consisted 4 sessions, starting from providing relevant alcohol and health information, identifying triggers for alcohol use, building motivation and basic skills to manage alcohol use, creating their personal plan, coping with anxiety and depression symptoms, and preventing relapse. These sessions were followed by 3 booster sessions reviewing their alcohol reduction goals, barriers to and facilitators of reaching those goals. So now this final intervention is implemented through randomized control trial. So HATHI study used hybrid type 1 effectiveness implementation design. In RCT, we enrolled patients with pulmonary TB with or without HIV who were within 30 days of TB treatment and reported unhealthy alcohol use as measured by Audit C score, which is more than or equal to 4 for men and more than or equal to 3 for women, with individual level randomization in 1:1 ratio, and participants were followed for 12 months. So our sample size for RCT is 450 participants with either TB with or without HIV, recruited from 2 sites, BJ Government Medical College and DY Patil Medical College Research Center. The primary endpoint is alcohol use at month 6, which we are measuring objectively using the biomarker PEth. And PEth was collected using the dried blood spots. Secondary endpoints at month 6 and month 12 include 3 self-reported alcohol use outcomes using the timeline follow back method. And we are also assessing TB outcomes such as cure, treatment failure, mortality, and adherence to and retention in TB care, as well as HIV related outcomes that includes viral suppression, adherence, and retention in care. So, HATHI intervention was delivered by counselors trained in motivational interviewing skills, and intervention sessions were conducted every 2 weeks, starting from study enrollment till 8 weeks during the study, followed by booster sessions at month 3, 4, and 6. And intervention supervision and fidelity monitoring was done by two behavioral scientists using the motivational interviewing coach rating scale, which evaluates counselors' skills in developing the intervention as intended. So, till mid August, we screened 710 participants with TB with or without HIV and unhealthy alcohol use, and enrolled 304 participants. Later in the study, we added HIV only cohort where we have enrolled 63 participants of 140 screened. So, if you see that our enrollment rate is 43 to 44% of the eligible participant, and the major reason for non-enrollment was strong refusals and critical medical conditions, and the retention in the study is at 6 months is 93%. Third phase of the study is implementation evaluation, and we are using RE-AIM implementation framework for assessing implementation barriers, facilitators, and costs. And we will document the patient level intervention reach and its effectiveness through our RCT recruitment data and with patient interviews. We will also conduct the interviews with counselors involved in the session delivery, as well as organizational and policy level officials, and these interviews will help us to understand the facilitators and the barriers to the adoption, implementation, and maintenance of this intervention. Cost effectiveness of the intervention will be assessed by using cost data collected through time motion studies and WHO's patient cost survey. So this table outlines the qualitative and quantitative implementation measures that will be used in the RE-AIM outcome framework. Lastly, I would like to share a few powerful success stories from our intervention participants, which highlight the real life impact of alcohol reduction intervention. On the left, we have a 30-year-old male who was diagnosed with both HIV and TB with audit score 23, and his story reflects how limited awareness and knowledge about the health consequences of alcohol was a key barrier. As he shared, I was not aware about all the effects of alcohol. I only knew that alcohol damages the liver. So he showed his appreciation to study counselors by presenting a handmade flower bouquet during session 2. The second story is of a 61-year-old male diagnosed with the TB and with audit score 21. And after participating in the study, he reported, "If I had not been enrolled in the study, I would have continued drinking alcohol immediately after being discharged from the hospital, and I certainly would have died. Now I take my TB medicines without fail, and my health is getting better." So these testimonials not only reflect a change in the behavior, but also highlight how awareness, counseling, and structured support can enhance TB treatment adherence and outcomes, especially among people with unhealthy alcohol use. And finally, I would like to acknowledge the support from study principal investigators from US, site principal investigators from India, our sponsors, NIA, and study participants, study team, and staff from India's National TB Program and HIV program. I am happy to take any questions. Thank you.